Well, that was a great talk, Priyanka. Thank you so much for the detailed talk. That was very, very informative. Thank you. And that brings us to our next speaker, who's also a co-director of this APP session, Alexandra Maltby. She is a physician associate with the Newton-Wolseley Heartburn and Reflux Program. And she's going to talk about management of anti-reflux surgery patients for the APPs. So over to Alex. Alex, welcome.
Thank you, Dr. Parantape. So yes, I'm a PA with the Department of General Surgery and the Heartburn and Reflux Program here at Newton-Wolseley Hospital. And I'll be talking about the management of anti-reflux surgery patients for the advanced practice provider. Our objectives for today, are to understand the post-op management for anti-reflux surgery patients in the inpatient setting and the outpatient setting, as well as to learn how to diagnose and manage post-operative concerns after anti-reflux surgery. So for the purpose of today's talk, we're going to be reviewing minimally invasive anti-reflux surgery, including laparoscopic and robotic hiatal hernia repair and fundoplication, which is when a hiatal hernia or part of the stomach that has herniated above the diaphragm is reduced into the abdominal cavity. And then the defect at the diaphragm is repaired. And then a fundoplication is created by wrapping the top part of the stomach behind and around the esophagus to create that anti-reflux barrier. We will also be discussing TIF, or transoral incisionless fundoplication. And this is a procedure that is done with endoscopy. There are no incisions in the chest or the abdomen. And it's ideal for a patient that either has no hiatal hernia or has a very small, like 1 to 2 centimeter hiatal hernia. So the scope is advanced into the esophagus and the stomach. It's then retroflex to look back up at the esophagus. And then the top part of the stomach is plicated to the distal esophagus, 270 degrees around to create that wrap. Because the success of anti-reflux surgery is so dependent upon patient selection, I felt that we could not talk about post-op management of anti-reflux surgery patients without going into a little bit of the workup done prior to surgery to identify those patients. So typically an upper endoscopy should be done, and this would be to look for obviously signs of esophagitis and reflux, looking for Barrett's esophagus. We're going to be able to see if there's a hiatal hernia, look at the lower esophageal valve. A barium swallow can be helpful to look at the overall motility of the esophagus. We can see reflux of barium coming up, and we can get an overall view of the anatomy as well. pH testing can be obtained to give us a baseline of the acid exposure in the esophagus. It can help us to correlate patients' symptoms with acid reflux events and help us to identify patients that might have reflux hypersensitivity. And then esophageal manometry is absolutely critical. It needs to be done prior to offering a patient a fundoplication to rule out dysmotility. So let's delve into the inpatient management. I'm not going to go through everything on these slides in detail, but I wanted to have the information. These slides will be up and available for you to reference back. So I wanted to highlight here that we really want to aggressively treat any patients that have postoperative nausea and vomiting after surgery, because retching and vomiting can, of course, place or cause a lot of pressure and potentially disrupt that repair and lead to an early recurrence. Similarly, we're going to start patients on a bowel regimen starting on post-op day 0 because we want to avoid any straining from constipation. And then some surgeons may order a barium swallow, and this would typically be done prior to advancing the diet and is useful to look for esophageal leak, early recurrences, and motility. Talking now about diet, activity, and length of stay in the hospital. So with diet, of course, there's going to be some surgeon-to-surgeon preferences, but everybody can agree that the diet needs to be modified initially after surgery because there's expected post-surgical edema at that fundoplication site. And advancing the diet too fast can lead to complications. So in general, patients are started on a clear liquid diet and then advance to fulls the following day if they're tolerating that well. Activity-wise, we want to get these patients up and moving around, ambulating as soon as possible on post-op day 0. We know that's just going to improve their rate of recovery overall. Regarding length of stay in the hospital, on average, our patients stay overnight, just one night in the hospital, and then they can go home. Some of our younger patients, especially those that are otherwise healthy, may have a higher chance of going home on post-op day 0, but that is really the exception rather than the rule. And of course, we want to make sure that they're tolerating their diet before we send them home. So one of our inpatient PAs, Emily Hunter, has created this hiatal hernia repair pathway. And this is something that is given to our nursing staff, our APP team on the floor, our interns and our residents. And it's great to get everybody on the same page. We're doing a lot of these surgeries and everybody needs to know what to do and what not to do. But what I wanted to highlight here is that our dietitian has actually created a special post-op diet for our patients. So we can actually place these orders in our EMR system. We use Epic. And so we know exactly what patients are getting and more importantly, what they're not getting on their trays. And this is key because if you order a clear liquid or a full liquid diet, there's actually going to be a lot of variation hospital to hospital, even between Newton Wellesley and Mass General. A clear liquid diet here versus MGH is completely different. So let's transition now to the outpatient side. So the patient has been discharged. Obviously, we're going to continue them on pain medication. In our practice, we allow our patients to take oral NSAIDs, but they must be taking a proton pump inhibitor because we want to avoid any gastric or GI irritation. And speaking of PPIs, the data is not really clear about when to stop these after anti-reflux surgery. It is our practice that we continue them through their post-op visit, just because of the post-op inflammation. So typically we stop them once we see them post-op, which is usually about 2 to 3 weeks after surgery, unless of course they have a history of Barrett's esophagus, in which case we would continue it. Of course, we're going to keep them on a bowel regimen to avoid straining from constipation. Antiemetics really should not be needed in the post-op setting and on the outpatient side. And if they are, that's a bit of a red flag. And then importantly, if a patient is taking a lot of vitamins or supplements, anything that they can really avoid for the first 2 weeks after surgery, they should, because it will decrease the risk of pill dysphagia. Similarly, if there are medications that they can actually crush, and we can go through that with them before discharge, that can be helpful too. So touching now upon diet, and this is a key part of postoperative management. So we know that surgery at the GE junction is going to lead to a normal and expected amount of edema, and that will cause some level of esophageal outlet resistance. And so again, following a diet post-op is really important. I am lucky enough to work with a dietitian in our clinic, and she has created a really comprehensive diet guide for our patients. So again, they're discharged on that full liquid diet, and they continue a full liquid and pureed diet for the first 2 weeks post-operatively. If they tolerate that well, then they can advance to adding in soft foods. After week 3, once they get to week 4, they can add in solids if week 3 is going okay. And then they fully advance over a period of 8 to 12 weeks. So having a dietitian, or at least having a diet guide in place, can really help to set expectations for the patient ahead of time. Okay, talking about activity post-op. So what we want to remember here is that we want patients to avoid any sudden increases in intra-abdominal pressure that can put strain on that repair site. So we are telling our patients to avoid any heavy lifting, any core-centered exercise, or anything too strenuous for about 6 weeks after surgery. However, we want them to get up, we want them to walk around pretty frequently. So I do want to talk about follow-up on the outpatient side, and Priyanka alluded to this as well for her POEM and POP patients. So unlike somebody that has had their gallbladder removed, where we see them 2 weeks after surgery and then they're discharged from the practice, these foregut patients, especially anti-reflux surgery patients, are followed long-term. So I have an example of what we do in our clinic on the slide, but what I wanted to highlight here is that at each follow-up visit, it's really important to talk with the patients about long-term management, right? So understanding that surgery is not a magic fix, it's not a magic cure-all, but when it's combined with really good diet and lifestyle modifications, it can really be successful long-term. And so making sure patients know that weight gain post-operatively long-term can increase the risk of a recurrent hiatal hernia. And then adopting those healthy diet and lifestyle changes like eating small amounts at once, chewing thoroughly, just eating mindfully overall will help them to have better success long-term. So what are some of the specific changes in management for somebody that has had a TIF, which again is that transoral incisionless fundoplication? We'll learn more about that tomorrow. So for one, there's a slightly higher chance of them going home on post-op day 0 because they typically have less pain. There aren't any incisions. Importantly, there are no changes to their diet initially. After the first 1 to 2 weeks, they typically advance much faster, but they do remain on the diet the same as the hiatal hernia repair patients initially. And although they tend to have a faster recovery, we tell them to continue to follow the same postoperative restrictions as a hiatal hernia repair patient because we don't want them putting any strain on that repair site. All right, let's transition now to talk about postoperative concerns. So the first concern that I wanted to discuss is dysphagia. So with dysphagia, what you really need to figure out is what is kind of normal and expected after surgery and when you need to be concerned. So first of all, figuring out where they are in their post-op journey. Is this patient, just a couple of days out from surgery and really struggling to get anything down? Are you worried about dehydration? Are they having a clinically severe amount of weight loss? It would be very unusual for a patient to be discharged if they're having these types of symptoms, but something to watch for. On the other hand, perhaps this patient is 2 months out from surgery. They've mostly fully advanced their diet, and now they're complaining of occasional difficulty swallowing, crusty piece of bread, right? Those are totally different situations. So ideally, you bring the patient in, you're going to get a really good history from them. You want to ask them, how frequent are these symptoms happening? Is this every time that you're eating? Is it with liquids or is it only with solids? Is the food bolus eventually passing through, or are you having to regurgitate or vomit up everything that you're eating? Is this happening when you're eating really, really fast, or are you, taking your time to eat? Is it happening when you are eating too much? So if you feel like their symptoms are more related to their diet and perhaps they're not following the diet guides, then troubleshooting their diet. So on the other side of my screen here, I have some tips. So making sure that patients are chewing really well before swallowing, staying upright, eating small amounts, taking enough time in between each bite. That can be really helpful. And then the other thing that can be useful is actually watching the patient take a sip of water in front of you. If they are visibly pained while they're taking that sip of water, that's a red flag. On the other hand, if they're able to swallow sips of water without any trouble, you can be a little bit more reassured. So if you are concerned and the patient's having dysphagia, you can consider getting a barium swallow. If it's normal and symptoms continue, you're going to need to proceed with endoscopy, potentially with dilation. On the other hand, if the barium swallow shows any signs of stricture or things are not passing through well, you're also going to need to do EGD. So during endoscopy, the endoscopist will be able to see if there's evidence of a tight fundoplication or stricture, see what's going on, and potentially dilate that patient. If that works well and the patient has improved symptoms, then there's a chance they could need a repeat dilation in a couple of weeks to months. On the other hand, if the endoscopy is completely normal, there aren't any concerning signs, but the patient continues to be symptomatic, then you may need to consider a further workup, looking for functional dysphagia, for example. Maybe repeating a motility study like manometry. And then if there is evidence that the fundoplication is too tight and the patient is not responding well to dilation or needs repetitive dilation, then considering the revision of the fundoplication. Let's talk now about return of symptoms. So, figuring out, first of all, what the symptoms are. Is the patient complaining of a burning sensation? Is it in the chest? Is it more in the epigastric region? Are they having a lot of reflux, regurgitation, dysphagia? And then what's causing it? Are there any triggers or inciting events? Is this happening when they're going out to eat and, having multiple margaritas and salsa and chips? Or is this happening on a daily basis and they're really doing a good job of following the diet? So establishing how often this is happening. That's going to help you to figure out what your differential diagnosis is. Do you feel like this is more diet and lifestyle related? Are they having, overeating a lot or potentially eating multiple trigger foods at once, just putting a lot of pressure on that repair site? Maybe they just had orthopedic surgery and they are taking high dose NSAIDs and aspirin for the past month, and now they have gastritis. Or are you concerned that they might have a recurrent hiatal hernia or a slip fundoplication? So based on your differential, your workup might include either a barium swallow, an endoscopy, potentially with a pH study, and a motility study like manometry. And then your treatment will depend on the cause. So again, working on diet and lifestyle modifications with the patient, potentially resuming medications or adding back in a proton pump inhibitor or an H2 blocker, always making sure that we're on the lowest amount of acid suppressing medicine as possible. And then if there is a recurrent hernia or a slip fundoplication and the patient continues to be pretty symptomatic, talking to them about redo surgery. And we'll talk about this tomorrow as well, but recent studies looking at long-term patient satisfaction have shown really great success rates. So key learning points are many post-op concerns can be managed with diet and lifestyle modifications, but knowing what those red flags are and when to intervene is key. Creating care pathways and diet guidelines can be helpful to reduce patient care errors and to help set patient expectations. And then close and frequent follow-up of anti-reflux patients is going to lead to long-term success. I would like to acknowledge my team, and these are my references.